Hello and welcome to MK's Medical Review series. My name is Dr. Moses Kazevu. We shall continue our electrocardiography series. These are a series of lectures that are meant to get you from being confused as a practitioner concerning the ECG to becoming an expert at reading the ECG. In our previous lecture, we looked at other rhythm problems that are affecting the atria and affecting the ventricles. We looked at the bradycardias, we looked at the extrasystoles. In this review lecture video, we're pretty much going to be looking at the tachycardias. Remember, in the previous lecture, we divided the heart according to the rhythm problems, as the rhythm could arise from the SA node, it could arise from a focus in the atrium, it could arise from a focus that is very near the AV node. So you collectively refer to those as supraventricular rhythms, or it could arise from the ventricle. You refer to that as a ventricular rhythm. The rule of thumb on the ECG is that if the rhythm is arising above the ventricles and there's nothing wrong with the conduction system in the ventricles, you're usually going to get a normal QRS complex or a narrow QRS complex. If the rhythm is actually being generated from the ventricles, then you get a broad QRS complex. So in this review lecture video, we'll look at the tachycardias. So remember that these are foci that could arise from the atria, they could arise from the AV node, they could arise from the ventricles, and they're going to be causing a repeated depolarization that leads to a sustained tachycardia. And the most important thing is to actually try and identify the P waves in these type of tachycardias. So we have supraventricular tachycardias, which could be atrial tachycardias, atrial flutter, as well as junctional tachycardia, which we shall talk about shortly. So with atrial tachycardia, here the atrium actually depolarizes faster than 150 beats per minute. Then note that the AV node usually has a delay to prevent the ventricles from being overstimulated before they can actually fill with blood, quote unquote. So the AV node actually is not going to be conducting any impulse rate that is greater than 200 beats per minute that's coming from the atrium. So if this is actually happening, that the atrium actually has a faster rate than 200 beats per minute, then usually it will appear as if the AV node there's an AV nodal block, or there's an AV block. So usually you get some P waves that are being conducted down the QRS complex, and some P waves are not being conducted by the QRS complex. So you may get some P waves and no QRS complex. So the difference between this type of AV block and second degree heart block is that here the AV node functions normally, and the reason why it's functioning normally is because it wants to prevent the ventricles from being activated at a faster rate, and therefore if they're being activated at a faster rate, they'll work inefficiently. Whilst in AV block there is a problem with the AV node. So also remember that in first degree and third degree heart block, there is usually associated sinus rhythm. The AV node, as well as the bundle of His, they do not conduct this impulse normally. So here is an image that is showing you atrial tachycardia. So after 3 sinus beats, so you have the first sinus beat here, a P wave, a QRS complex, a T wave, a P wave, a QRS complex, a T wave, a P wave, the QRS complex, and the T wave. Then all of a sudden the P wave here is superimposed on this T wave that preceded this beat over here. So you can see that this P wave here is superimposed on this T wave. Then obviously you have a normal QRS complex throughout, indicating that the impulse is being carried normally within the ventricles. Then with atrial flutter, remember that here the atrial rate is much greater than 250, and usually there's no flat baseline between the P waves, so you get kind of like a sawtooth appearance of the P waves, quote unquote. So as we can see here, the P waves are being carried at a much faster rate, at about 300 beats per minute, and not all the P waves are being passed to the AV node. So it means that not every P wave is going to be followed by a QRS complex, and these QRS complexes, as we can see, they are of normal duration and they have normal morphology, indicating that the impulse down the QRS complex is normal. So as you can see, there are about 4 P waves that usually precede a QRS complex, and the rate of the ventricular activation is here at 75 beats per minute. Then you may also get what is known as atrial flutter with a 2-to-1 block. So here you have to pretty much look at the P wave, and you should recognize and see if there are any extra P waves, meaning that there's a P wave that wasn't conducted to the ventricles. So a narrow complex tachycardia with ventricular rate of about 250 should always point you towards the possibility of you having an atrial flutter with a 2-to-1 block. And take note that to identify these arrhythmias, you should look at the lead that has the best P waves, or the best looking P waves, or the P waves that are easy to identify, which is usually lead 2. But of course, if we have a full 12 lead ECG, please look at the rhythm strip as well. So with atrial flutter, like I said, it's very easy to identify it in lead 2, but obviously we can see it in lead AVR. And remember that the P waves and pretty much almost all the other waves are inverted in lead AVR. We can also see this in lead AVF. So here is an ECG showing you atrial flutter with a 2-to-1 block. So atrial flutter, in atrial flutter here, the atrial rate is about 200 or 300 beats per minute rather, and as we can see, there is a 2-to-1 block. So there's going to be a ventricular rate that is much lower than the atrial rate. So here it's almost like half the rate of the atrium, so it's about 150 beats per minute. So the first, as we can see, the first of the 2 P waves are each associated with the QRS complex. So as we can see, there's a P wave that's associated with the QRS complex. The first 2 beats, the P wave associated with the QRS complex. Then after that, remember that what do you call this? The first 2 P waves that are associated with each QRS complex can sometimes be mistaken for a T wave of the preceding beat. So please do not mistake this as a T wave for the preceding beat, but the P waves can be identified by their regularity in the trace, and the T waves here, it's very difficult to identify them. So these things that appear like as if they are T waves here, they're not really T waves, but they are rather P waves. So as you can see here, you have a P wave, which here, QRS complex, here's another P wave, here's another P wave, QRS complex, a P wave, here's another P wave, a QRS complex. It's very hard to distinguish the T waves in this ECG. So here is an ECG showing you atrial flutter with a 2-to-1 block. So usually the first thing that you're going to be doing is look at the lead where you can identify the P waves very easily. And in this case, lead 2 is where you can identify the P waves very, very well. You could also do this in lead AVR, though it would be very confusing in lead AVR because the waves are pretty much inverted. So I would advise you to look at lead 2. So as you can see in lead 2, the P waves here are calculated at a rate of 300. Again, if you can't really see this image is very nice, I'll leave a link in the description below where I shall post these lecture presentations where you could actually download them and actually zoom them and confirm these details that I'm telling you about. While at the same time, the QRS complex here is regular and it was going to be having a rate of 150. You can actually see that this QRS complex is here pretty regular from these chest leads, showing you a normal QRS complex in this ECG. And of course you have normal T waves, which we can best see in the chest leads, and they are very difficult to distinguish the P waves from the T waves in these limb leads. As you can see, it's maybe from lead 1 here, but it's very, very difficult from seeing. So this is atrial flutter with a 2-to-1 block. Then sometimes when you have atrial flutter, you may perform what is known as carotid sinus pressure. So this carotid sinus pressure can actually help you to make a diagnosis, or it could actually be therapeutic in some types of arrhythmia. So it's actually therapeutic in supraventricular tachycardias. Remember, whenever you are applying pressure now over the carotid sinus, which is just near the angle of the mandible, if you apply pressure there, you stimulate the vagus. So you activate this vagal reflex, and remember the vagus usually slows down the SA node and it will slow down the AV node. So once you do this, then you're simply going to be reducing the frequency of discharge of the SA node, and you're going to be increasing the delay of the conduction of the AV node. And this may help the supraventricular tachycardia, so it may help a patient. So if you get a decrease in the conduction of the AV node, it is important in making the diagnosis as well as treatment of this type of arrhythmia. And remember that carotid sinus pressure is actually going to show or slow the ventricular rate in some supraventricular tachycardias, and it may actually even completely abolish others. But if it's coming from the ventricles, there is no effect at all. So as you can see here, we had a patient that had atrial flutter, and then carotid sinus pressure was applied here at this point here when this person's ECG was being taken. And then when now we applied this carotid pressure, this carotid sinus pressure, as we can see, we increased the blockage, the heart block. So it means we increased the delay in the conduction of the impulse from the SA node to the AV node and to the ventricle, such that here, as you can see, there are not so many QRS complexes as compared to before here. So obviously this will point you towards atrial flutter. As you can see here, we also have this sawtooth appearance. Then you can also have junctional or nodal tachycardias. So here there is depolarization that's happening around the AV node. The P waves happen to be actually very close to the QRS complex, and they may actually look like extrasystoles, or you may actually not even see the P waves at all. And usually the QRS complex is of normal shape because the ventricles are being activated in a normal way via the bundle of His. So on top, at the bottom here, you have a sinus rhythm. So where you have a P wave, a QRS complex, a T wave, a P wave, a QRS complex, a T wave. So this is a normal sinus rhythm. So here you have a junctional tachycardia. So as you can see here, there are no P waves that you can see in this ECG, and the QRS complexes appear regular. Here the QRS complexes are appearing irregular, but no P waves. So this is a junctional tachycardia. So in this same patient, here's the lower tracing of sinus rhythm. So as you can see that the QRS complexes are actually pretty much the same with the junctional tachycardia here compared to sinus rhythm. Here is an ECG showing you supraventricular tachycardia. So let's look at lead 2 over here. So as you can see, there are no regular P waves. We don't know if these look like T waves here. So as you can see, this looks like a T wave, this is a T wave here, this looks like a T wave. It's not really a P wave. So there are no P waves that we can actually notice from this. So if we even look at lead AVR over here, these look like T waves. So there's no P wave that we can actually see here. The QRS complexes are pretty much regular, and they will have a rate of 180 beats per minute here, and they are narrow and they are of normal shape. The T waves here, as you can see, these are pretty much normal. So the T waves are normal. So this is usually a sinus or a supraventricular tachycardia. Usually when we treat these, we could apply some carotid pressure, and then we could actually give them adenosine if it's necessary. Then with the ventricular tachycardia, remember that here the focus is coming from the ventricular muscle. So it's coming from the ventricles at a much faster rate or higher frequency, and usually this causes in effect a rapidly repeated ventricular extrasystole. So you have these extra beats that are happening in the ventricles. So this excitation that is being created in the ventricle spreads via an abnormal pathway within the ventricle. So it means that even the QRS complex is going to be wide and it's going to appear abnormal. So the wide and abnormal QRS complex is usually seen in all the 12 leads of the ECG, but remember that wide and abnormal complexes are also seen in bundle branch blocks. As you can see, here is ventricular tachycardia. We can't see any P waves on this ECG. Usually there are regular QRS complexes at a rate of 200 beats per minute in this case, and the QRS complexes are pretty broad. So usually they're longer than 240 milliseconds. We can't even see any T waves here because the ventricles aren't really repolarizing in a right manner. Then how do we distinguish ventricular tachycardia from supraventricular tachycardia with the bundle branch block? So if a patient who has an acute myocardial infarction has a broad complex tachycardia, it's always going to be a ventricular tachycardia. But if a patient with an episode of tachycardia that doesn't have an infarction, then it could either be a ventricular tachycardia or it could be a supraventricular tachycardia with a bundle branch block. So how do we distinguish ventricular tachycardias from supraventricular tachycardias with bundle branch block? So distinguishing between these two is very important. So the first thing that you want to do is first you find your P waves and you see how they relate to the QRS complex. You should always look at the 12-lead ECG very carefully. So if it's possible, compare the QRS complex during the tachycardia with the QRS complex during sinus rhythm. So if the patient has a bundle branch block, when they're in sinus rhythm, the QRS complex during the tachycardia will be the same shape and the same morphology as the one that you see in normal sinus rhythm. That's if they have a bundle branch block. It means that inherently there's a problem that's affecting the conduction of this impulse in the ventricles. And if the QRS complex is greater than 4 small squares, which is 160, then most likely the rhythm is ventricular in origin. You may sometimes get left axis deviation during tachycardia, and usually this is going to be pointing you towards a ventricular origin, as does the change of axis when compared with what you record to sinus rhythm. So if you have a left axis deviation in tachycardia, then it means that there's a ventricular origin. And if you have a left axis deviation also in sinus rhythm, then it is pointing you towards the ventricular origin. Then if during the tachycardia the QRS complex is irregular or very irregular, then the rhythm is probably atrial fibrillation with a bundle branch block. So here's a sinus rhythm with the left bundle branch block. So remember that each QRS complex is going to be preceded by a P wave, and there's going to be a constant PR interval in this same ECG. But if we look at the QRS complex, they are wide and the T waves here are going to appear inverted. So this trace here was gotten from lead V6, and as we can see here, there's an M pattern here and inverted T waves here, which are very characteristic of left bundle branch block. If you still haven't watched the video on left bundle branch block, please go watch the video on left bundle branch block, then you understand why you get this M pattern. Then sometimes you may get fibrillation. So remember that in all the arrhythmias that we've talked about up to this point, there was the whole muscle of the atrium, the whole muscle of the ventricle were contracting at the same time, even though they were contracting at abnormal speeds, but they were contracting at the same time. So in fibrillation, that's where you get these individual muscle fibers that are contracting independently. So you think of the heart, or you say that the heart is fibrillating. So you could have atrial fibrillation, you could also have ventricular fibrillation. So remember, when the atrial muscle contracts independently, there are usually no P waves on the ECG. We only see an irregular line. So we call these as flutter-like waves, or F waves, which usually happen for about 2 to 3 seconds. And remember that this AV node is going to be constantly bombarded with these depolarizations that are coming from the atrium of varying strengths, of varying durations, and they'll have these irregular times that are coming to the these irregular intervals that are coming to the AV node of the impulse. And like I told you, the AV node conducts in an all or none fashion, so it's a no-nonsense type of guy. So what is going to happen is that these depolarization waves are going to be passing through the bundle of his at a constant intensity. So only a certain intensity is allowed to pass through. So however, these waves are going to be irregular, so the ventricles are also going to be contracting irregularly. So because this conduction is happening in an irregular manner in the atrium, but then they're being conducted in the ventricles in a regular manner, you get a normal shape of the QRS complex. So in the 12-lead ECG, fibrillation is often much better seen in some leads than it is in other leads. So here's an example of atrial fibrillation. As we can see here, there are no P waves. There are no P waves that you can see on this ECG. We'll look at lead 2 here. There are no P waves. So there's this irregular baseline where it's not really flat. Okay, it's supposed to be flat and with some P waves over there. So you have this irregular baseline, and you also get these QRS complexes that are happening at irregular intervals at a rate of varying between 80 to about 180 beats per minute, but you have a normal shape of the curious complex, indicating that the conduction is normally within the bundle of His. Then of course you have depression of the ST segment that is happening in leads V5 as well as lead V6. As you can see here, there is an ST segment depression that is taking over there, and of course the T waves are normal in these leads. So this is what's happening in atrial fibrillation. Then you also have ventricular fibrillation, where the ventricular muscle fiber is actually going to be contracting independently. So you won't be able to see any curious complex that you can easily identify, and the ECG will be in total chaos. So usually the patient is going to lose consciousness because effectively the heart won't be contracting and pushing out blood to supply the vital organs. So by this time you would have long realized that there's a change on the ECG pattern, and it's actually very easy to make a diagnosis of ventricular fibrillation. So as you can see here, this person had these beats, and then all of a sudden this chaotic pattern happened. So this person here had ventricular fibrillation, and most likely they passed out and they were unconscious. So the focus is coming from different areas or individual muscle fibers contracting. Then another important aspect is WOLF-PARKINSON-WHITE syndrome. Remember when I talked about the PR interval being short, I gave you two possibilities. It's either there is a focus that is in the atrium that is very close to the AV node, or you have an accessory bundle or an accessory pathway that is conducting the impulse from the atria to the ventricles at a much faster rate. So in WOLF-PARKINSON-WHITE syndrome, usually there is this extra or accessory conducting bundle between the atria as well as the ventricles, and it's directly connecting the atria and the ventricles, bypassing the AV node. So it means that there won't be that AV nodal delay. So a depolarization can actually reach the ventricles much earlier than it's supposed to be and cause pre-excitation. So how do we see this on the ECG? Look for two important things. So you get a shortened PR interval that's less than 3 squares, and then the curious complex will actually be slurred upwards, giving you a delta wave. I'll show you a picture very shortly. So the second part of the curious complex is usually normal, as the conduction through the bundle of His usually catches up with the pre-excitation. Then the only clinical importance of this anatomical abnormalities is that it can predispose someone to developing what is referred to as paroxysmal tachycardia. We'll talk of tachycardias as a topic on their own, so if you do not understand this from the ECG, please do not worry. We shall talk about all these conditions and how we manage them later on as we grow the channel. Then remember that this depolarization can spread down the bundle of His. It will also spread down this accessory pathway. So they are kind of like two pathways. One pathway which conducts slowly, and another pathway that conducts very quick. So it means that the one that is quick to conduct, the impulse was also going to be quick to depolarize and quick to repolarize. Then the one that is slow in conducting the impulse will be slow to depolarize and slow to repolarize, such that an impulse can move down the pathway which is the fast pathway, and by the time it's reaches this other slower pathway, it can depolarize this slow pathway, and then the impulse could keep circling in the same place, and then you get what is referred to as a re-entry circuit, and then you can lead to a sustained tachycardia. So here is your WOLF-PARKINSON-WHITE syndrome. So if we look at the PR interval, it usually tends to be shortened like that. As we can see, the initial part of the curious complex is slurred. It's not like a straight line, but it's kind of like a sloping line that is over there. It's actually more evident here. It's kind of like a sloping line that you can see over there. As you can see here, you have a sloping line that is over there. So you call those as delta waves. You get a short PR interval, and as we can see, lead 1 is facing downwards, lead AVF is facing upwards, so there's a right axis deviation here. There's a slurring of these waves in lead V3 and lead V4, and of course there's also a dominant R wave here in lead V1. We shall talk about what the dominant R wave is when we look at ventricular as well as atrial hypertrophy. Here is a sustained tachycardia with WOLF-PARKINSON-WHITE syndrome. Obviously, this is due to re-entry tachycardia, so there are no P waves that you can notice on this ECG. So where do these tachycardias usually come from? There are some mechanisms that have been postulated. One mechanism is that there is increased automaticity or enhanced automaticity. There are certain drugs and certain conditions that could predispose an individual to this. The other thing is the re-entry circuits that can be created, like for example in WOLF-PARKINSON-WHITE syndrome. Usually there's no clinical significance in distinguishing whether this is due to increased automaticity or re-entry circuit on the ECG, because that has no practical value. So here's a summary of the things that we have talked about. So here you have an abnormality, what happens to the P wave, what happens to the P to QRS ratio, what happens to the QRS regularity, the QRS complex shape, the QRS rate, as well as what rhythm do you get. So take some time to actually look through this diagram or this table and actually understand it and see what is going on. So in the abnormalities where the P waves are present, you get these abnormalities here. Where the P waves are absent, you get these abnormalities here. And each of them have different connotations or different meanings that you should look through and actually understand. So how do we manage these arrhythmias? So here I'll give you principles of management. I won't give you exactly the drugs and the dosages and stuff, because we'll cover those as separate topics on their own. I'll just give you a general outlook. So for the fast or the slow sinus rhythms, always treat the underlying cause. Don't treat the rhythm, don't treat the ECG, treat the underlying cause. The extrasystoles, usually we don't do anything about it. But if we get a patient that is in acute heart failure, or someone who is in shock, who has a low BP, that is that is due to tachycardia, usually we perform direct current cardioversion, and you should consider doing this much early on. And for patients that have bradycardia that is affecting the circulation, they have to be treated with, of course, atropine. And if this is ineffective, then they may need a pacemaker, which could either be temporal or a permanent pacemaker. Now, first, we usually treat any abnormality of a tachycardia with carotid sinus pressure, and usually we should do this carotid sinus pressure with an ECG running, because it may help us determine or make a diagnosis. For example, if you have a sinus tachycardia and you apply the carotid sinus pressure, it temporarily slows the heart rate. If you have an atrial or junctional tachycardia, you apply the carotid sinus pressure, you may actually stop the arrhythmia, or it may have no effect. And then of course, if you have an atrial flutter, if you apply carotid sinus pressure, usually you're going to increase the heart block. So you may change it from a 2-to-1 to a 3-to-1, where you get 2 P waves, from 2 P waves, 1 QRS complex, to 3 P waves and 1 QRS complex. If you have an atrial fibrillation or ventricular tachycardia, usually with carotid sinus pressure has no effect. Then if you get a normal complex tachycardia, usually we treat this with adenosine. If you get a wide complex tachycardia, we usually treat this with lignocaine. But of course, there are different drugs and a different classification for treating these arrhythmias, which we shall cover much later on. So here's an ECG of someone who had a pacemaker inserted. So as you can see, there are some occasional P waves that are visible, and these P waves are not really related to the QRS complex. And the QRS complex usually preceded by a spike. So as you can see, there's a spike, and so that represents the stimulus of the pacemaker. And the QRS complexes are broad because the pacemaker actually stimulates the right ventricle and causes ventricular beats. Thank you for taking your time to listen to this review lecture video on rhythms of the heart. Until next time, my name is Dr. Moses Kazevo. Bye-bye.